my name is Domenica Lema, and today I go to tell about Ruxolitinib for glucocorticoid-refractory acute graft-versus-hotst disease. Definition: acute graft-versus-host disease (GVHD) is a major limitation of allogeneic stem cell transplantation. Not all patients have a response to glucocorticoid treatment. Ruxolitinib and selective Janus kinase inhibitor show potential efficacy in patients with acute glucocorticoid refractory GVHD.
So GVHD, or graft-versus-host disease, is an immune reaction where the donor's T lymphocytes recognize minor antigen differences on the surface of the cells of the patient and try to react against them. And in a sense, the graft tries to reject the patient instead of the patient rejecting the graft. And we talk about acute and chronic GVHD. By definition, acute GVHD is any reaction that occurs within the first 100 days after transplant, and chronic GVHD is reactions that occur after 100 days. But that's somewhat oversimplification. There are some differences in the mechanism of those reactions, and there can be overlap. So some patients may have what looks like chronic GVHD earlier than day 100, and conversely, some might have acute GVHD that comes on after day 100. But that remains one of the biggest challenges to success from transplantation. And fortunately, there are some improvements being made. Ironically, Ruxolitinib, which is the
Applications in medicine. Ruxolitinib is used to treat myelofibrosis or polycythemia vera, which are disorders of the bone marrow that affects the body's ability to make blood cells. Treatment of graft-versus-host disease in adults and children at least 12 years of age.
Shows up as diarrhea, or of their liver, which can cause their liver blood tests to be abnormal, or they can get jaundice or yellow skin. When they get a rash, sometimes it involves the palms and soles, and occasionally it can involve the rest of the skin on the body from the head to the toes. In order to diagnose graft-versus-host disease, we will often perform a skin biopsy, which is a straightforward procedure that can be done in clinic and has relatively low risk. Sometimes the skin biopsy will confirm a diagnosis of acute graft-versus-host disease, and then we often start by treating with topical corticosteroid creams as well as with wet dressings, which can make the steroid creams work that much better. Some patients will benefit from the use of UV phototherapy, which can be administered in a dermatologist's office. When a patient develops a severe rash, then we'll partner with hematology and oncology to change the patient's systemic immunosuppression, such that the graft-versus-host reaction is calmed down. Patients following stem cell transplantation can also develop other rashes, and one of the next most frequent types of rashes that we'll see is a reaction to a medication. Now, sometimes these can be itchy, and sometimes they can look like...
And cons. Use of Ruxolitinib as a second line in treatment of acute corticosteroid-refractory GVHD. Cons. May increase your risk of developing skin cancer, and it is not approved to treatment myelofibrosis or polycythemia vera in anyone younger than 18 years of age.
Different from what you're talking about, where we can manage someone as an outpatient. With the type of gastrointestinal graft-versus-host disease that falls into the severe category, putting out a lot of diarrhea, these patients have to be hospitalized. And when we think about that hospitalization and the length of stay, we're talking about weeks to maybe a month or two. So for the patients, this is a big diagnosis. They're coming off of a long hospitalization with their transplant. When we think about the things we need to do, the first step is really diagnostically. What do we do to work this patient up? We may be suspecting that graft-versus-host disease is the cause of their diarrhea. However, these patients are also very immunocompromised. From their transplant alone, we first will rule out infections and make sure that's not a contributing factor here. We will also consult our GI colleagues for the patient to undergo a flex sigmoidoscopy for biopsies to be taken. While that's happening, we also, as you mentioned, we will typically start.
Use it applies in Ecuador. Treatment of graft-versus-hotst disease, a complication of a hematopoietic stem cell transplant in adults and children over 12 years of age who were unsuccessful treatment with steroid medication.
Supplementary drugs that control the inflammation of GVHD but do not inhibit the immune system, and Ruxolitinib fits into that category. So this is a way of adding a drug to our baseline framework of corticosteroid therapy that can reduce the inflammatory components, reduce the abnormal cytokine production, and contribute to a remission induction without fully compromising the immune system. Without any definitive clinical trials being available, a number of years ago, many transplant clinicians started to use Ruxolitinib because of its beneficial effects in preclinical data in mice. And I think this was in significant degree amplified by a paper by Robert Zeisser that was in Blood several years ago, which was not a clinical trial. It was an accumulation of European experience in the use of Ruxolitinib in patients with steroid-resistant, both acute and chronic graft-versus-host disease. And albeit an experiential analysis as opposed to a clinical trial, I think it was convincing that the drug was useful, and I think many of us.
Conclusions. Ruxolitinib therapy leads to effective improvements in efficacy. Result signs mechanism of action is different. It has a insectable toxicity, and it is being used to treat graft-versus-host disease in adults and children with a minimum of 12 years old.